Welcome to your last lecture. This one is on burns. So this is for Complex Care, Nursing 456, Chapter 20. And again, it is the last lecture and it's covering burns. With burn treatments, you have to remember that your initial management affects whatever the patient's long-term outcome will be. Burn centers have come along and made significant difference in the care of burn patients. It is a multidisciplinary and team approach. Burns actually account for the highest morbidity. The higher the surface area, the higher the chance of morbidity. So burns that cover more than 50% of the body's surface area increases the morbidity. The older the patient or the younger the patient significantly increases the risk of morbidity. Just a little refresher about the integumentary system or the skin system. It is comprised of two layers, the epidermis and the dermis. Then you have the subcutaneous fatty tissue layer under that. The different roles that the skin plays is to protect us from infection, prevention of loss of body fluids, thermoregulation, the production of vitamin D, well, a lot of people forget about that one, excretion, determination of identity. Remember, we have fingerprints, we have heel prints, we have toe prints. All of those are very individualized. We have to worry about sensation reception. That's also a role of the integumentary system. So what about the effects of aging on the skin? Well, you start getting flattened dermal epidermal junctions. The dermal and the subcutaneous layer begin to atrophy as you age. There's a reduction in the microcirculation of the skin layers. There's the consequences of this is what we call thin skin. Their thin becomes paper thin. There's a predisposition to deeper burns. There's a delay or a significantly poor healing effects. And then, of course, this is complicated by a decreased ability for patients to tolerate a burn stress as they age. And then having thinner skin increases the burn depth. So the different types of burn injury mechanisms, there's thermal, chemical, electrical, and then inhalation injury. With thermal injuries, the skin is damaged by direct contact with heat. This would be a flame, a heat source, or some type of scalding liquid. The severity of the injury is determined by the duration of the contact with the agent, the temperature of the agent, how much tissue was actually exposed, and of course the age of the patient. So in a critical thinking question, what would be some examples of a thermal injury? And why do you think the young and the elderly are at an increased risk? For chemical injuries, the methods of injury are contact, inhalation of fumes, and then either ingestion or injection of the chemical. Chemical injuries can have both systemic and local effects. The chemical must be completely removed or completely neutralized, or the damage will continue to build and continue to worsen. All of you should have heard about material safety data sheets. Working in a hospital, working around chemicals, there's all kinds of chemicals, floor wax, bleach, toilet bowl cleansers, all kinds of stuff. Well, there's also material safety data sheets regulated towards toxic medications. We give toxins. Remember, we give anti-neoplastic medications to cancer patients. Those can be considered chemical injuries depending on what you do with those. A lot of those medications are very caustic when you touch them. Another chemical injury would be acid, battery acid. That's a chemical injury. So for chemical injuries, again, the severity of the injury also depends upon the type of the agent, how much of that agent was in the exposure, how long the contact was maintained with the agent, and how concentrated that agent is. There are different types like an alkali, an acid, and then there's even organic compounds, chemical compounds. For electrical injuries, we're talking about high voltage versus low voltage. Anything that is over 1,000 volts is high voltage, and less than 1,000 volts is considered low voltage. Remember that energy is converted into heat, so electrical burns cause thermal heat injury as well. We have to remember we have alternating current and direct current electrical injuries. Alternating current has a higher probability of producing cardiac arrest. A critical thinking question would be, how can electrical injury be prevented, and why is the damage often unseen when it's an electrical injury? With inhalation therapy, there is carbon monoxide poisoning. You can have an injury above the glottis or below the glottis. Burns are classified based on a classification system and the severity. It depends on the type of burn injury. It also depends on the burn wound characteristics such as depth, the extent of the wound, and the number or body part that was burned. Are there any concomitant injuries involved? What is the patient's age? What was the pre-existing health status of the patient prior to the burn? All of these are considered in the classification and the severity of the burn. The last thing that's considered is the depth of the injury. Was it superficial? Was it partial thickness? Or was it all the way through full thickness of the skin? A superficial burn is considered a first-degree burn. This is where the epidermis only, or a small depth of the dermis, is damaged. The healing will occur in 3 to 5 days without any actual real treatment. Erythema will be noted, and it's not a calculation for fluid resuscitation. We don't do fluid resuscitation for a first-degree or superficial burn. A partial thickness is considered a second-degree burn. This is where you have all of the dermis and all of the epidermis and most of the dermis is burned. There are subclassifications of superficial partial thickness and then a deep partial thickness. Depends on how much of the dermis is burnt. With the superficial partial thickness, the epidermis and a limited portion of the dermis is damaged. This will heal in about 10 to 21 days. The deeper partial thickness is all the epidermis and most of that dermis, and it takes a little longer. It takes about 3 to 6 weeks for healing to occur. With full thickness burns or third-degree burns, there's destruction of all layers down to or past the fat, the fascia, and maybe even to the muscle or bone itself. There's a thick, dry, leathery appearance to the area, and there is no pain. The patient's area is insensate. In other words, the nerve endings have been burned away. The patient will be insensate with full thickness third-degree burns. And I've kind of already answered this question, why is there no pain with a full thickness burn? And remember, that's because those nerve endings have been completely burned away. With burns, they will also talk about zones of injury. There's a zone of hyperemia. This is when there's minimal injury. A zone of stasis. There's potentially reversible damage in that zone. And then there's the zone of coagulation. This is the zone of greatest injury. Such as when we talked about ischemia, we have the different zones, and the more centered the zone, the more damaged. Well, we also have the same type of zones of injury with burns. This just diagram gives you a little bit more information or a little more visual for the zones of injury. The left-hand section of skin is a superficial burn, and you can see how far down it goes into the dermis. But then the one on the right is a full thickness burn, and you can see that the injury loop goes all the way down past the dermis into the musculature. And you can see the segmented sections of zones, coagulation, stasis, and hyperemia. With burns, the extent of the injury is expressed as a total body surface area percentage, and so that's a percentage TBSA. There are several methods for estimating this. Most of the time you will always see the rule of nines used because it is the most rapid way to do so. However, there is a patient's palm method where you measure the size of the patient's palm, and that's what you do. And then there's also one called the Lund-Browder chart. There are differences between adult and children methods of estimating. So when there's a burn, the local response of the skin to the burn is acute inflammation, intravascular coagulation, cellular enzymes and vasoactive substances become active and start shifting around. There's activation of the complementary systems, the stress systems, and then you get altered vascular permeability related to the damage. Fluids start shifting around. Fluids will shift to the extravascular space, especially with burns that are more than 20% TBSA. The edema in the burned and unburned areas are going to be different. You'll have much more edema in the burned area and more weeping. Maximum edema occurs about 24 to 48 hours post-burn. And then you have to be very careful about a burn shock. This is a combination of distributive and hypovolemic shock. So when you put distributive or neurogenic and then hypovolemic shock together, you get what we have a potential for a burn shock. So the cardiovascular response to burns is there's that loss of intravascular volume due to the fluid shifting that then affects cardiac output by decreasing cardiac output. The body then tries to compensate by causing tachycardia and vasoconstriction. There's something called a host defense mechanism where we have an immunosuppression issue as well as increased risks of infection with a systemic response to the burn. The pulmonary system response will be, you will see some pulmonary hypertension, and that's usually an effect of direct pulmonary lung injury, such as inhalation or burn due to either heat or smoke inhalation. Renal response, there'll be a sensitivity to that decreased cardiac output that happens, and then there will be an initial decrease in urine output related to a decreased GFR or glomerular filtration rate. This then is followed by a diuresis as your fluids continue to shift and you start volume resuscitation. So again, in the cardiovascular system, you have a loss of volume, decreasing cardiac output, and this then affects your oxygen delivery. Your catecholamine release causes a tachycardic vasoconstriction reaction in addition to the low volume. So you get a myocardial depression with negative inotropic effect. Your cardiac output can increase 48 hours after the injury. This can lead to diuresis then. With the GI system, there's some ischemia due to the redistribution of blood to the brain and the heart. So the GI system is the part that loses their blood flow to compensate for brain and heart. You can get a paralytic ileus due to this decreased blood flow. And then there's something called Curling's ulcers that has to be taken into consideration. Metabolic responses is that you become a hypermetabolic state. It can last up to 9 or 12 months after the injury. So the different phases of burn care. Well, the first one is a resuscitative stage. This is the emergent stage. It is the first 48 hours after the burn. We're really watching ABCs, airway, breathing, circulation. This includes the pre-hospital time, the ambulance ride. And this is a lot of fluid management because we're preventing burn shock, we're preventing distributive shock and hypovolemic shock. The next phase is the acute phase. This is where we get onset of diuresis and we actually start getting wound closure. The last phase is the rehabilitative phase. This is where the body starts to try to restore to functional status. So, the assessments in the resuscitative phase. Looking at the respiratory system, you always want to assess for airway, breathing, circulation. So airways first. Assess for hypoxemia. You want to look for possible carbon monoxide poisoning. Assess for direct burn injury to the lung or the airway. And then make sure that you are maintaining cervical spine precautions because that affects respiratory. So a critical thinking question, what are the cues for thermal injury to the airway? And if tracheal edema is suspected, what is the best way to manage the airway? So with the cardiovascular assessment in the resuscitative phase, fluid volume status is your biggest deal here. That is going to affect your vital signs, your hemodynamics, and then of course carbon monoxide poison will affect cardiovasculature, can cause an MI because we have an oxygen deprivation to the myocardium. A critical thinking question here is what patients would likely benefit from an insertion of a PA catheter? And what is an important risk to consider when determining the need for a PA catheter in a burn patient? Ongoing with the assessment and resuscitative phase, neurologically, we have to assess for changes in the level of consciousness. Renal, urine output is your key trigger here because volume it's all about volume. GI, again, you want to assess for occult bleeding, look for bowel tones, bowel sounds, observe for possibly ileus because remember it has decreased blood flow to the GI system. It's been shunted to the brain and the heart. The integumentary system, the biggest thing here is to document the extent of the injury, measure the severities of the burn using one of those methods, the rule of nines, the Palm method, Lund-Browder chart, and then of course psychosocial. Assess the patient's response to the injury. Make sure you're looking at pain assessments and appropriate pain treatment. And then psychosocial is really big. This is a huge, monumental, long-term rehabilitative issue. There are definitely going to be some psychosocial issues here, if there aren't already before the patient even has a burn involvement. So during the EMS pre-hospital interventions, the biggest things that we're looking for them to do is to remove the source of the thermal damage, look at the ABCs, do the cervical spine precautions, deliver oxygen at 100%, intubating the patient if required, assess the circulation, remove any clothing and jewelry that can be done so without harming the patient, and then assessing for any additional trauma. EMS is going to be responsible for covering and preventing hypothermia, seeking large bore IV catheters and initiating fluid resuscitation is significant here. And of course, pain management with narcotics is a huge deal, unless they are insensate. Vital signs, baseline assessment is all going to be what you're going to start and use as your trending. So they are the beginnings of the emergent recovery phase. Critical thinking challenge, why do you think it's important to remove all the clothing and the jewelry early on? Why is it important to start the IV lines immediately? And why is pain treated with IV narcotics? What is the pain drug of choice for a burn patient, do you think? So once the patient is delivered to the emergency department, interventions are kind of ongoing, but they expand a little bit. So we're looking at ABCs, of course. We're going to do a C-spine evaluation, see if we can eliminate C-spine precautions. We're going to do circulation checks. We're going to assess the need for eschorotomies or fasciotomies. We're going to do that fluid resuscitation calculation based on one of our tools, either the nines, the Palm measurement, or the charting, Lund-Browder charting. Ringer's lactate is the IV fluid of choice for fluid resuscitation. You're going to get a chest x-ray, you're going to try to sink a nasogastric tube, and then, of course, pain management, appropriate pain management for the patient. Fluid resuscitation, remember it's lactated Ringer's, and it's based on the percentage of the total body surface area that's burnt, using either Rule of Nines, Lund-Browder, or the Palm method. The IV fluid resuscitation is instituted for patients that have greater than 20% TBSA burning. So for adults, the fluid resuscitation guideline is to have 2 to 4 milliliters per kilogram per percentage of total body surface area burned. You want to administer half of the total fluids during the first 8 hours from the time of the injury and the first 8 hours. Then you're going to administer the last half over the next 16 hours. After that initial 8, the next 16. You want to maintain a urine output of 30 to 50 milliliters an hour. Place those IV accesses in non-burned areas, and you want to hold colloid fluids for 8 to 12 hours after the injury. And I'm going to ask you why. Why do you think you want to hold colloids for 8 to 12 hours after the initial injury? The fluid guidelines for an electrical injury, these patients with electrical injury need higher volumes of fluid. So we want to keep their urine output at 75 to 100 milliliters an hour. The reason is that electrical injuries results in release of myoglobin, which can cause acute renal failure, so we're going to increase the amount of circulating volume and dilute that myoglobin. So for practice, I want you to calculate the fluid requirements for a patient who weighs 80 kilograms and has an 80% TBSA burn. If the fluid resuscitation was not started until 2 hours after the burn, how does that affect the fluid administration? Okay, so we have limited access burn centers. So you want to transfer your patient to a burn center early on and do it according to criteria. So if there is partial thickness of greater than 10% total body surface area burn, you're also going to transfer them if they have full thickness burns. If there are any burns in the face, hands, feet, genitalia, perineum, and joints. If it's a chemical or electrical burn, or a chemical and electrical burn, excuse me. If it's an inhalation burn. If the patient has comorbidities, which is almost everybody in this day and age. And then if there's any associated trauma, you want to send them to a burn center, as they deal with these things much more frequently than regular emergency departments, and the burn centers can deal with these things more appropriately and more promptly. What do you think are the essential interventions that need to be done during transportation, and why are patients with injuries to the hands, face, joints, perineum transferred to a burn facility? Why do you think those specific things are significant for the patients to go to the burn center? So during acute phase assessment, you want to continue with all your resuscitative phase assessments. And with the respiratory system, you're going to start looking at signs of respiratory compromise. We're doing a lot of fluids. We want to monitor for any issues with that. Chest x-rays are going to help us. You want to treat any fevers. You want to look at their respirations and secretions. You want to look for any WBCs, pus, and you want to look at their CBC and WBC counts. For the cardiovascular tour, you want to maintain a fluid requirement, monitor strict INO, and monitor their weight. For neurological status, you want to assess for any changes in their level of consciousness. For their renal status, it's all about urine output and renal function. For the GI system, we have to be very careful about stress ulcers. We have to worry about nutritional considerations and starting this nutrition as soon as possible. The integumentary system, of course, we're very concerned about infection. With fluid and electrolytes, we've got a lot of fluid shifts going on. We're going to have a lot of electrolyte imbalance potential. Acute care interventions in the primary and secondary surveys, ongoing assessments of the vital signs, your pulses, your urine output, and your pulse oximetry. Other interventions would be hemodynamic monitoring, gastric pH monitoring, occult blood testing, daily weights, fluid administration and monitoring, which is your eyes and nose, maintaining joint function and mobility, doing passive and active range of motion. So again, you're going to ongoing monitor respiratory, cardiovascular, GI, renal, fluid, and electrolytes. It's very important to prevent hypothermia. You're going to monitor your labs, your x-rays, ABGs. You're going to look for lactic acid buildup. Some special concerns to look at: facial burns. Well, these patients are at a higher risk for respiratory injury. Oral hygiene is of concern, and you want to promote healing. Ears. You have to be very, very careful about ear breakdown, tissue breakdown, and loss of the auricle completely from the head. Eyes. Ophthalmology consults need to be done as soon as possible, and your eyes need to be kept moist, especially if there's any eyelid burning where they're just removed from the burn. This becomes significant. With the hands and the feet or your major joints, you want to make sure there's adequate circulation and maintaining function of hands, feet, and joints. Genitalia and perineum, you want to have meticulous wound care because of infection risks. These are two photographs of burn patients. Some are burns, some are grafting. Just a little idea of some of the fluid shift and the edema that you can see on patients. They begin to look like Michelin men. A few extra little miscellaneous issues you have to be concerned about. Was the burn caused by abuse? Is this a vulnerable population issue? These vulnerable populations are children, geriatrics, disabled, and the mentally impaired. You have to watch for identification of potential cases. Elicit their history. What does the wound appearance and pattern look like? Take photographs. Observe interactions between the patient and their family members, and look for any potential other injuries or significant instances of potential abuse. Pain control is one of the major factors with burn patients. It needs to be adequate, and you need to use accurate assessment tools. Opiates are the narcotics of choice using the IV route. A patient-controlled analgesia or PCA may be useful, allowing them a little more control over their medication and assisting. There's also non-pharmacological strategies to use in pain control. For your critical thinking question, identify the many procedures that can increase patient pain when they are a burn patient. When should pain medication be administered to prevent pain? With infection control, your burn patient is at a high risk for infection. Because of the altered skin, we have altered immune responses. Those infection risks are particularly high with people who have a 30% TBSA or more. Multiple invasive monitoring and treatment procedures also increase the infection risk. So what are the potential sources of infection in a patient with burns, and how do you think that infection can be reduced in a burn patient? So wound care in burn patients, you're going to be removing non-viable tissue. This will help promote coverage of the burned area, and then skin grafts will be used as needed. When you're cleaning and debriding wounds, a Hubbard tank is the best way to do so. You're going to apply antimicrobial agents when you're doing this, and there's open dressings versus closed dressings. So be sure to look at that. There are now a variety of types of biological and biosynthetic dressings that they use for burn care. Grafts are used for deep partial thickness and full thickness burns. Some different kind of grafting. Autografting is the only permanent method for grafting. A homograft and a xenograft can be used. Sheets of non-meshed grafts are used on the face and the hands, and then we use meshed grafts on torso and the peripheral extremities. So A, B, and C here. A is them grafting, meshing onto an arm, and then B is how it's when it's first put on. And then C is as the skin starts pulling that grafted skin into play for healing. It starts, this is actually skin that's been perforated into a mesh format, and then it's stretched over the area and then stitched in, and it can be incorporated to the patient's own skin. So critical thinking is evaluate the pros and cons of the different various dressings available. Nutritional support is significant with burn patients. They have to be worried about being in a hypermetabolic catabolic state. Dietary consults need to be done to determine the caloric needs of the patient, and early enteral nutrition is very warranted with burn patients. Psychological considerations, of course. A burn not only affects the patient, it affects the entire family. There will be long-term effects. You have to consider what was the pre-injured personality, what's the extent of the injury, what is the social support system of the patient and the family, what's their home environment. A critical thinking question: what are the many psychosocial outcomes of burn injuries? And what are strategies for addressing the psychosocial needs of the patient with burns? Geriatric considerations. Older patients are more adversely affected by burn injuries. They have multiple variables that will affect their outcomes, because like comorbidities and such. You need to target interventions to maintaining quality of life and reducing pain. And preventative measures are essential with the geriatric patient that's been burned. Some non-burn injuries that mimic burn-like injuries. There are some syndromes that will do this. There's severe exfoliate disorders like a toxic epidermal necrolysis, Stevens-Johansson syndrome, erythema multiforme, staphylococcal scalded skin, necrotizing soft tissue infections such as staphylococcal scalded skin and necrotizing fasciitis. Patients may need to be treated in the burn unit for these particular issues. The only issue is that there's no fluid shift with these particular syndromes. They do have a burn response, but there is no fluid shift because there was no actual burn. So, critical thinking question: what are the strategies for promoting rehabilitation early on in the course of burn management? And what multidisciplinary team members participate in burn care management? And as always, please bring your questions to class. Your question may not be the only question, or you may not have you may not be the only person asking that same question. Thank you, and I will see you soon.